everyone. I'm Sherry with the CGH Health Foundation. Welcome to our Growing Healthier program. This is an educational series that's sponsored by the CGH Health Foundation. Our Growing Healthier programs, we try to educate you about important health topics and also take the opportunity to introduce you to some of our very knowledgeable health professionals. And our programs are hosted by Dr. Bill Bird, our Chief Medical Officer at CGH. February is American Heart Month, and today Dr. Bird's going to be joined by Dr. Hassan Kieso from our CGH Cardiology Department to discuss our heart health and all of the cardiology services that we offer here at CGH. So whether you need preventive care, urgent care for heart attack, or cardiac rehab, we'll help you recover from that, and our team will have your heart well in hand. Before we move on to our program, let me tell you that the CGH Health Foundation mission is pursuing healthier lives for people in the Sauk Valley, and we do that by providing assistance through our many programs and initiatives, and some of those include our dementia project, oncology services for our cancer patients, our Ways to Wellness program where we connect our patients with valuable services. We have scholarships, pediatric mental health, our women's health program, transportation assistance. We do nutrition education in local schools through the Catch program. We fund that. We fund the Eyeglasses for Kids program, the Prescott Dental Health Clinic, and those are where our dollars are spent. And the programs are funded by donations from hundreds of individuals, businesses, clubs, churches throughout the Sauk Valley. So if you'd like to join them, there's still time to make a gift to the CGH Health Foundation. All of the contributions will be received through the end of April. That's when our campaign ends. And our goal for this year is $550,000. Before I turn it over to Dr. Bird and Dr. Kieso, let me tell you about next month's program. And that's going to be on Thursday, March 14th. And we will be talking to nurse practitioner Concha Sitter from our gastroenterology department at CGH. And she's going to be talking about colorectal cancer and covering things like symptoms to watch for, screening guidelines, and new prep options that are available to prepare for your colonoscopy. So that program will be next month again on March 14th. And now I will turn it over to Dr. Bird.
Thanks, Sherry. You know, we were talking, we're getting pretty creative with these titles. So I think Rebecca came up with one for Concha. So, you know, we're living on the edge. That's how that's how we roll here at Facebook Live. All right, so looking forward to today. We're going to be talking to Dr. Kieso. And for those of you who are watching this, if you have heart disease, you don't want to have heart disease, you have some sort of family history of heart disease, I think you're going to find some information here that's going to be really helpful for you. So stay tuned in, and I'm going to pull in Dr. Kieso. Dr. Kieso.
Hello.
Welcome.
Thank you.
Dr. Kieso's a busy man. Just before we're on a couple minutes late because he had to work. He had some work to do for a patient. So I'm glad we have a few minutes here to catch you and talk about some heart-related questions. Are you ready to rumble?
Yes, thank you.
Okay. All right. I think let's start out with a question about preventing heart disease. And I'm going to throw this in kind of a decade kind of category of, if you were talking to someone in their 20s, someone in their 40s, someone in their 60s, someone in their 80s, what would you suggest to them to try to help prevent them getting heart disease at some point in time in their lives? And does that change at all as the decades go by in terms of what prevention looks like?
Yeah, that's a very important topic, and there is a common theme that runs across the various decades, and the common theme is controlling and reducing and, if possible, abolishing the factors that lead to heart disease. So if you're talking about a 20-year-old, you don't want them to start new habits that may have, or even earlier than that, habits that would impact their health later. People in their midlife, we want them to stop things they have already been doing and change their lifestyle, and people later on in life to avoid things that may exacerbate or aggravate problems they already have. But the common thread to all those is risk factor modification. The way we live, the way we eat, the way we exercise, all these things. And there has been a gradual generational change in how society behaves. I mean, there's less physical activity, there's more food, and more kind of less healthy food, if I may use the term. And all these factors contribute to the development of heart disease. The earlier you intervene, the better the outcome will be. So, for example, you tell them not to smoke and also not to vape. I mean, sometimes people say vaping maybe, well, less like it's not. It has its own health hazards and probably becomes more prominent and well known as it becomes more widely used. Secondly, you don't want to be drinking too much. You do want to eat healthy. Um, Avoiding stress is always a factor, but I think the more important is learning how to cope with stress, because you're not going to be able to abolish stress, but it's a fact of life and you have to be able. Controlling your blood pressure, having regular checkups, controlling your cholesterol, or at least knowing what your cholesterol is, and then acting according to what advice you get.
Yeah, very good. Thanks. You know, I was thinking about this as I wrote the question, as you're kind of talking about it, that you alluded to this. I probably should have started with preventing heart disease literally when you're from the time you're born. You know, in terms of like how the how you go about eating and how active you are, because it just all adds up at some point in time.
Right.
Some of us more than others in terms of our hearts.
Absolutely. Yeah.
And the other thought I was thinking about was, um, I'm wondering more and more about like heart disease and thinking of it as like kind of like a chronic inflammatory condition. So like, you know, if you don't eat healthy foods, if you don't exercise, if your blood pressure stays too high, if you weigh more than you should, all those things kind of seem like they create inflammation in our blood vessels, and slowly but surely over time, that puts you at higher risk of having some type of blood vessel disease. And we're talking about the heart today, but it could be any blood vessels.
Yes.
Your thoughts on that?
Absolutely. And that's the common theme now. There are even, in some cases, suggestions of using anti-inflammatory agents, or at least studies on being made on studying the inflammatory response as a marker of the disease going on in the vascular system, including the heart. Also, some attempts at treating the vascular disease with an anti-inflammatory basis. And you're right, because there is a battle going inside our arteries, and this is between cholesterol getting into where it shouldn't be inside the vessel wall, and the body responding by sending those macrophages. These are the foot soldiers that will try to clear the cholesterol and clean it, and a big battle happens. And as a result of that, you get these plaques building up, which are like little volcanoes covered by a very thin mantle. And every now and then, this plaque ruptures, and the gruel is released and causes an acute heart attack. So that's the process going on all the time.
Yeah.
And
one of the things as you say that too, that I was just going to make mention of, you mentioned people are talking about what kind of anti-inflammatories perhaps they could take. One of the anti-inflammatories that since I was a kid, the mantra was an aspirin a day keeps the doctor away. Or maybe it was an apple. Either way, I'm just curious now. What is the evidence from a cardiology standpoint about whether aspirin is something that someone who is at risk of having heart disease should take before they even have heart disease?
Yeah. Well, there are two kinds of prevention. There's primary prevention, and that is the general population who've not had manifestations of heart or vascular disease yet. And then there is secondary prevention, that is people who've already had clinical manifestations, had a stroke, had a heart attack, had bypass surgery. Secondary prevention in this group of people, yes, aspirin, everybody should be on aspirin, and we'd go to pains to make sure they are on aspirin. Unless there are some reasons they can't take it because they can't tolerate it or have GI bleed or something because of the aspirin. However, for primary prevention, as you rightly said, until recently, it was very popular and very seductive to take this simple medication, aspirin, which is hardly a medication. People think of it as candy, and but it is such a powerful drug. So the current recommendation is that for people between 40 and 59, taking aspirin for primary prevention is kind of individualized. If you are, say, 45, 50, and you have no risk factors, you are healthy, you exercise, your cholesterol is good, you're not diabetic, then probably the risk benefit doesn't work. It's not worth you taking aspirin. It's not. But if you are in the same age group, but on the other hand, you have some diabetes, you have a strong family history, then you haven't had coronary disease yet, it may be worth considering an aspirin a day. That's kind of an individualized decision depending on the patient and their circumstances. So there are some circumstances that increase the risk, then maybe take aspirin, but the net benefit's not going to be that high. There is some risk of intolerance or other side effects. If you are 60 years and older, it's not recommended to take aspirin for primary prevention because there's more likely.
Why is that?
Because likelihood of problem bleeding and complications from aspirin. So if you are 40 to 59 and otherwise healthy, super healthy, probably no need for aspirin. If you have risk factors in that age group and you want to take aspirin, fine, but you have to realize that the net benefit is not going to be that dramatic. Thirdly, if you already have, if you are more than 60, it's not recommended to take aspirin as a primary prevention.
You had mentioned, we've been talking about risks some here, and what I'm curious about also, Hassan, is are there, we just think in general of risk, are there specific algorithms or something that you look at with your patients in terms of a specific number that their risk is that you use?
Yeah. The American College of Cardiology and the American Heart Association publish these risk calculators, they call them. And they calculate the risk of somebody developing clinical manifestations of cardiovascular disease in the next 10 years. And they go into age, sex, high blood pressure, cholesterol, smoking, diabetes, and they come up with a risk. So they can tell you if your risk is 0 to 5%, that's a low risk. If it's 5 to 19% risk in 10 years, that's moderate. And then the more than 20% risk, that's high risk. So this is the calculation that can be made using those, and they can be downloaded onto cell phones, also onto mobile phone, and you can easily determine your patient's risk over the next 10 years and plan accordingly.
And I'm guessing, and you can do that in your home. You can just Google that. And
yeah.
I'm sure you'll find one that you could go with. I guess so let's say someone is watching us and says, oh, I'm curious. I know what my cholesterol is. I know what all these kind of factors, and they plug it into the algorithm and they are high risk, which, as you just said, is defined as, for most of those algorithms, greater than 20%. If they were to come in to see you, what would you usually suggest in terms of treatment to reduce their risk of having heart disease within the next 10 years?
I think, again, we go to the common theme in all this, and this is risk factor. Attack the risk factors they have. So ask about family history of people having, we call it early onset coronary disease, so that a parent or a first-degree relative or a first-degree cousin who's had manifestations of heart disease, and if it's a male, in their 40s or 50s. If it's a female, up to the age of 60, 65, considered early coronary disease. Then after they ask about their habits, do they smoke? Do they have high blood pressure? What is their cholesterol? What is their LDL? I tell patients call the lousy cholesterol, LDL, or the low density cholesterol. What is their HDL? So there are different patterns existing. And there are new risks being discovered and also being kind of studied. Still the work is going on. Lipoprotein little a, it's going on HDL. We don't have a good medication to raise HDL, although some are in the pipeline, but still we're not at that stage yet. So basically, you look at their risk factors and what their habits are. Do they smoke or do they exercise? And then ask them to modify the things that are modifiable.
How about those people that are kind of in between? They're not low, they're not high risk. What do you suggest? And I'm going to throw on top of that, do you ever suggest those kind of people do like a, we have these cardiac score CT scans, like we have those here at the hospital that we have a really good price for folks. What do you suggest for folks in that category?
Yes, if people have risk factors and they're concerned about their possibility of having underlying coronary disease, doing a calcium coronary score is useful in two ways. It's useful in diagnosing that you do have heart disease or likely to have heart disease. And secondly, in giving you a prognosis and telling you how bad the situation is, or how severe, let's say, a gentler word, how severe the situation is. So you use it usually in people between the ages of 40 to 70, because if you do it in people older than 70, there is a very high likelihood it will be abnormal. If you do it in people under 40, again, very less likely to be positive. So in this group, with some risk factors, they have family history, they have high cholesterol, or they had mildly impaired blood sugar, and so on. So you do the CT calcium score, and this gives you if it's positive, it indicates you have ongoing coronary artery disease. Because when you have coronary disease, it is a process, as you said, of inflammation, but the inflammation is healed with calcification. So calcium means there has been an inflammation there, and this is probably associated with inflammation elsewhere. It doesn't pick up the non-calcified plaque, which is also available and could give you trouble if it ruptures, but at least it's a marker that you have to look at these patients with more aggressive ways of improving their risk factors. And basically, it's read as a score. It's called Agatston score. Agatston is a cardiologist in Florida who's still practicing, and he's the same gentleman who devised the South Beach diet. Very, very knowledgeable gentleman, very, very nice to hear for him speaking. And so if your score, which depends on how many lesions you have, how thick the calcium is, if your score is 0, then the likelihood of having a clinical cardiovascular problem in the next 5 years is 0. If your score is 1 to 99, this is mild risk. If it's 100 to 399 is moderate risk. If it's more than 400, this is high risk. So when you come to the moderate and the high risk, obviously you have to be more aggressive with bringing their LDL down, controlling their blood pressure, encouraging exercise, and so on. So that's how it helps you.
Yeah, very good. And by the way, for folks who are watching, I just went by a billboard that our marketing department put up about this, and there we go. So it's only $76 to do that heart check CT scan, for just in case you're interested in doing that if you're one of those moderate risk individuals. So, okay, good. Okay, so let's go down the path now of those individuals who, they've done what they could do to try to prevent heart disease, but they haven't. So that happens. I mean, it's just part of how the human experience. It is a large number of us get heart disease at some point in time.
Right.
So, Dr. Kieso, can you give us? I think we do a really good job of doing procedures to help patients who have heart disease here at CGH. Can you speak to those procedures that we do here at CGH to help out patients?
Yes, actually, it's quite exhilarating to have so many things available to us here. I mean, we're getting those devices and things even in the right time. We're not too late in getting them. We're getting them early, and the hospital is investing. We have a lot of, for example, on the cardiovascular side, we have the lithotripsy, which is the ultrasound fracture of plaque, calcified plaque, and to enable delivering of stents. We have the ability to suction blood clots from pulmonary arteries and coronary arteries. There's the penumbra system, for example. We have physiological studies, and that's a growing field. That's a cutting edge. You do a coronary angiogram, you don't find any blockages, but the patient's still getting pain. And now some of these people have problems of the microcirculation, which we don't see, but we can indirectly get an idea by measuring some physiological parameters that tell us there is a microvascular problem that needs to be treated maybe differently than what we treat with the macrovascular, which is the usual stenting. So
I'm sorry for interrupting, but is that this index microcirculatory resistance?
That's what it is. Yeah, there's the CMR, IMR, IFR, and FFR. So there are all these, and we have the newest wire, which tests several of these indices by the same wire.
Yeah,
it's quite
about those. Just let's talk briefly about what we're talking about in terms of what that patient would present like. So, give me the scenario of a patient who would benefit from this. Basically, looking at the very, very small blood vessels in their heart to see if that's what's causing their symptoms.
Right. They would have chest pain, suggestive of angina. It may occur at rest or may occur on exertion. You do an EKG, you may or may not find changes, and you do a coronary angiogram and you don't find anything, and yet they may respond to the medications that you give for angina, whether nitrites or calcium antagonists, and that's when you have to think that maybe it's the microcirculation that's causing the problem and not the macrocirculation, because we've checked that and we don't find anything there.
So they're the people that like seem like there's something going on, but at least in the past when we've done the angiograms, we go, oh, well, we don't see anything here.
Right.
Now we can actually do this test, and maybe there is something going on. And if there is, then you give them medication, I take it, to help them with that.
Yes, nitrates and calcium antagonists.
And if there's nothing that we see there, then it's a lot easier for those patients to say, you know what, I understand you have that pain. I don't think it's your heart. There's something else in your chest area, your upper abdominal area that perhaps is causing those symptoms. Is that kind of how the conversation goes?
There is always the question of referred pain. I mean, people may have pain, especially over the left side of the chest, which is not from the heart. It could come from the diaphragm. It could come from below the diaphragm. Could come from the neck, referred pain from degenerative changes in the spine. So it could be referred pain as well. Not every chest pain has to be cardiac in origin.
Good. And I know we do this. Okay. I think she meant to say staff. How much do you love the cath lab staff? 1 to 10, with 10 being the best. This is from Jordan. You see that?
Yeah. What I'll say, I mean, for everything else, the hospital has this secret weapon, which is the staff it has. We have a great staff. I'm very happy to be working with them.
Well said. You didn't have to give a number, and I think everyone kind of knows where you're standing.
Yeah, 10, of course.
And then I think you may have alluded to this, but we have this IVUS system, this intravascular ultrasound system, to kind of be able to better evaluate people who have heart blood vessel lesions. Can you talk about that for a moment?
Yes. Well, IVUS is basically looking inside the artery. You can assess. Sometimes you see a lesion, you're not sure is it significantly narrowed that needs to be addressed or not. And this helps us by studying the degree of the lesion. We study the size of the vessel. When you deploy a stent, it helps you determine the size of the vessel. If there are any complications, it also helps because it adds more information than just looking at the angiogram. So it gives us a more detailed picture of what's going on.
Yeah, and I understand that maybe has some ability also to decrease the amount of contrast that we use when you do that kind of procedure too.
Yes, with more information, yes, you could do much less because you're more focused on the lesion.
Yeah, good. All right, what's Diana have to say? You see that, Dr. Kieso?
I'm sorry.
It says the Agassiz test, his score is 2445 and hers was 2.8.
Right, yeah.
Yeah.
The only thing is about the Agassiz score, if you get a negative score in a young person, it may still be that they have plaque that's not calcified, which may cause trouble as well. But for all intents and purposes, if you get a 0 score, then that's wonderful. The next 5 years, you're safe. Some people would, may be repeated after 5, 10 years, only in this group who are negative, to make sure it hasn't increased or nothing has happened in the meanwhile. But if it's high from the beginning, there's no point in repeating it, because you already know it's high.
Also, we do electrophysiology. You want to talk about that briefly too, Dr. Kieso?
Yes. Well, electrophysiology, is study of the electrical system of the heart, and there are many aspects of it. One is they can contribute to the treatment of heart failure, because sometimes in heart failure, when there are some EKG changes, the two pumping chambers are not working in synchrony. So this synchrony of the two chambers causes damming of blood in the lungs and causes heart failure. And so here they can synchronize both ventricles to beat at the same time, and therefore it is a more efficient circulation in the lungs and the heart. Secondly, they can also treat rhythm problems. So some people have very slow heart rates, and this happens with time. With age, the electrical system of the heart kind of wears out, and people start developing slow heart rates or big pauses. They pass out. So here, putting a pacemaker would help prevent this. They also treat very rapid heart rates by ablating the mechanism. Ablation means you apply high energy waves to certain areas in the heart to interrupt the cycle that's causing this rapid rate. So either atrial fibrillation or flutter, and we do the atrial flutter ablation here. And there are other forms of ablations that are hopefully will be done here in the future, but that's an active process too.
Yeah, I thought I would just add to that. I know our newest electrophysiologist, Dr. Ovadia, comes to us with a lot of experience and has done a lot of ablations where he's been at before. And we just purchased a system that will allow him to do those ablations here. Dr. Kieso mentioned atrial fibrillation. That's the one that, for those of you who are watching, that we're probably going to wait a little bit on that one, get our feet wet with the other type of ablations like the A-flutter that Dr. Kieso is referring to, and then probably explore the atrial fibrillation at some point in time. And also Dr. Olshansky has been here for a number of years, and he does a good job as well as electrophysiologist for us here at CGH. So, okay. I wanted to just also talk about I'm just going to say this because you may not want to toot your horn, but Dr. Kieso and Dr. Singh are excellent. And the thing that we do here at CGH that are really is part of our mission in taking care of our community is if someone comes in with a heart attack 24/7, 365, we are there to help them out. And so, I mean, that's a niche that we are very much want to take on here in our area. And Dr. Kieso and Dr. Singh have done a really good job with that. I know you've had, of course, in your time here, have had a number of patients that have had active, what we call STEMIs, but essentially heart attacks going on that you've been able to take care of.
Yes. Yeah, and in STEMIs, time is of the essence. The earlier you intervene, the better the outcome. Time is muscle. So the idea is to open up that artery as quickly as possible, as efficiently as possible.
One other thing I just wanted to ask you about is, sometimes patients will have some type of heart procedure, have something going on with their heart, and then the heart is a muscle. And so because it's a muscle, there's an opportunity to improve that functioning with rehabilitation. So can you kind of speak to when you would send someone for cardiac rehabilitation, when you would suggest that they go see Kelsey, Lindsay, and Pat, our nurses over in cardiac rehab?
Yeah. Actually, rehabilitation has achieved an important role in the management of heart disease. So you go to the hospital, or you're diagnosed with whatever heart condition you have. The next step is to continue with cardiac rehab. What rehab does, it increases the confidence. I mean, after a major effect, like a heart attack, you're kind of shell-shocked for a while. You're afraid how much to do. Some people do the opposite. They overdo it and they say, I want to check how much I can do. But with rehabilitations, it's a structured exercise program. It's monitored. So people modify the amount of work and the kind of work you do according to your situation. You start with a warm-up period of 5-10 minutes, then active exercise for 30 to 45 minutes, and then you cool down for another 10 minutes. And this is all repeated 3 times a week for 12 weeks. So, and it's paid for by Medicare, by the insurance companies. So it is a must actually to do a rehab for people who've had a heart attack, had a stent, newly diagnosed heart failure, following bypass surgery. We send them to the to rehab. The problem is not many people, take this advice. Some because of transportation issues, some because they have to be at work, and that is a problem sometimes we have. And it's all over the country. It's not here. The referral rate or the take rate of people accepting rehab is only about 30%, 30%. It should be more than that in this group of people. And rehab is generally safe. So one major event will happen for every 60 to 80,000 hours of rehab. So it's really very safe because they're observing you, they're watching you, and I think it's very important that all the categories I mentioned should be encouraged to go to cardiac rehab. What does it do? In effect, it lowers your blood pressure, lowers your heart rate, it improves your efficiency. It may contribute to lowering your cholesterol, may contribute to losing weight, or at least putting you on the right path to think of losing weight. And then it may contribute to improving your blood sugar control. So it's wonderful, free, cheap, painless. I think it's something that should be encouraged in everybody.
Very good. All right. Diana is asking, what are your thoughts about the Watchman?
Yeah, Watchman is a technology to decrease the incidence of blood clots in people with atrial fibrillation. Basically, it's a plug you put in the left atrial appendage, which is a kind of outpouch of the left upper chamber of the heart. And this tends to have sluggish flow there, and blood swirls around and makes clots, and these clots may cause strokes. Now, usually we treat them with blood thinners, but some people cannot take blood thinners. They bleed or they're intolerant and so on. So they devise this plug to block the artery. I don't do them. We don't do them here, but from what I hear is that it is fairly successful and fairly efficient. The only thing is that if you're doing it because the person cannot take blood thinners, you still have to give them blood thinners for the first 3 months, but that's temporary. You can tide them over, and then eventually it should be helpful. Long-term results, I don't know, it's been in use for about 5-10 years only. So down the road, we'll have to wait and see.
Yeah. Very good. All right. Well, thank you all for the questions. And Dr. Kieso, thank you for your time. I have a feeling you have some work to get to, so I'm not going to keep you. Let you get to it.
Thank you for the opportunity. Yeah.
Yeah. Good talking with you. All right. Thanks, Dr. Kieso.
Thank you. Bye-bye.
Yeah, I just hope the folks, those of you who are watching are going to watch this later, just what I wanted to impress upon you, I hope you caught as what Dr. Kieso was speaking, is that we have really good cardiac care here at CGH. And yes, we're trying to do all we can in our offices to prevent people from having heart disease, but should you acquire it, there's a lot that can be done for you here locally to take care of your heart issues. So I just wanted to make sure that thank you. I appreciate you putting that up, Rebecca. So, okay. I know we have some reminders that we wanted to, or shout outs also. I want to congratulate Nicole as Employee of the Month. Nicole works in our emergency department. Yes. So if you haven't been by the hospital, you would see we have a lot of construction going on in our front entrance. And part of that construction is that our gift shop is moving closer to the cafeteria. It looks really nice what our folks have put together for that. So as a result of that, we're trying to not have to move any more merchandise than we have to. So stop by and see if you can find some deals. All right. What else we have? Oh, yeah. And then Concha is going to be, I'll be interviewing Concha next month. Stay one step ahead of your behind. I don't know how I'm supposed to say that, Rebecca. But nonetheless, I said it without blushing. So, okay. That's what we have for today. Once again, I'm Dr. Bill Bird, Chief Medical Officer at CGH. Thanks for taking the time to join me for this episode, and we'll see you soon.